This patient presents with jump knee gait, which is characterized by spasticity of the hamstrings, hip flexors, and plantar flexors. The patient presents with equinus, hip flexion, and knee flexion. She also has increased lumbar lordosis and anterior pelvic tilt due to the hip flexor spasticity. Throughout gait, the upper extremities are holding on to the assistive device for stability, so there is no reciprocal arm swing. The center of mass is also shifted anteriorly throughout due to trunk and hip flexion. Stride and step length are shortened because there is a lack of hip extension bilaterally, lack of push-off from plantar flexion, and a lack of dissociation of the lower extremities. Hip adduction and internal rotation is often present in gait because of medial hamstring spasticity, weak quadriceps, and femoral anteversion. Upon initial contact, instead of a heel strike, there is a forefoot contact only due to plantar flexor spasticity. In the loading response, hamstring spasticity and quadriceps weakness prevents knee extension. The hips remain flexed and the ankle remains in plantar flexion. During mid-stance, the patient is unable to reach terminal knee extension due to previous mentioned muscle spasticity and weakness. Terminal stance and pre-swing have the same characteristics as plantar flexion spasticity has kept the ankle in plantar flexion, preventing push-off for swing. True hip extension does not occur due to hip flexor spasticity, which prevents an adequate hip flexor burst from occurring. This shortens the step length. Initial swing presents with a lack of dorsiflexion, lack of additional knee flexion, and adductor dominance, which causes a circumduction at the hip to clear the toes. During mid-swing, the inability to dissociate lower extremity movements does not allow for true mid-swing to occur. Terminal swing is characterized by a shortened phase overall because the overall swing phase is decreased in individuals with spastic diplegia.
Learning to walk again. I believe I've waited long enough. Where do I begin?
Stretching of the spastic muscles will help in the management of contractures and will allow more efficient movement to take place. Plantar flexor, hamstring, and hip flexor stretching will be most useful in this patient. When stretching the plantar flexors, the therapist should make sure that the knee remains extended without going into hyperextension. Hamstring stretching is performed in the 90-90 position, making sure that the contralateral hip does not bias into flexion during the stretch. Hip flexor stretching is performed by doing bolster rollouts. The trunk needs to be carefully monitored to make sure that it stays in a safe, neutral position. Bridging on a plinth will help with reducing spasticity in the lower extremities by introducing weight bearing to the joints. The bridging motion also helps the patient reach hip extension to neutral, and it strengthens the lower body. A ball placed between the knees will help limit adduction. The therapist can use handling techniques at the ankle to ensure the patient keeps the soles of the feet on the plinth. A method for strengthening the abductors is using sidestepping in the parallel bars. This may be facilitated by the therapist tapping on the abductor. Initially, the patient may not be able to take a large side step, but the patient should be encouraged to increase the step size by verbal cueing or by placing an object on the ground for the patient to step over. Toe tapping can be used to strengthen the dorsiflexors concentrically and eccentrically to help decrease equinus during gait. The therapist may have to initially guide the foot until the patient has enough control to perform the action independently. Then targets can be placed on the step to provide the patient with a motivation to tap a spot with control. A hand table can be used to provide the patient with stability, but care should be taken to ensure the patient does not fully rely on the upper extremities for support while completing the task. Strengthening with the use of ankle weights and the patient in sitting helps isolate the quad muscles. The strengthening of the quadriceps shows a decrease of knee flexion during stance phase and improves the stride length during gait. Step-ups are a higher-level strengthening task that encourages dissociation of the lower extremities. A therapist can encourage extension of the stance leg while guiding the swing leg forward with dorsiflexion and decreased adduction. The patient may need to use upper extremity support and initially may have difficulty performing the task with the most efficient movement patterns. Stepping back down the stairs with guidance aids in increasing eccentric control of the anterior tibia on the trailing limb, as well as stressing the importance of foot flat on initial contact. Ambulation on the stairs with guidance can greatly improve all gait kinematics because stairs isolate key motions of the gait cycle. In patients with spastic diplegia, the sit-to-stand task generally takes longer, especially during the extension phase. This is due to weakness in the lower extremity extensors, spasticity in the flexors, and a discoordination in the equilibrium and righting reactions. The upper extremities are often used in aiding the push-up from the chair and are used to increase balance during the center of mass transfer. During the flexion momentum phase, the patient positions herself in increased knee flexion to begin the center of mass movement. This increased knee flexion remains throughout the momentum transfer stage. Hip and knee extensor weakness is often to blame for this occurring. During the momentum transfer phase, there is no tibial translation due to the inability to reach dorsiflexion past neutral. The knees adduct and often remain touching throughout the rest of the task. The medial diving of the knees occurs due to abductor and quadriceps weakness and hamstring spasticity. This phase can appear to be occurring asymmetrically due to a unilateral retraction of the pelvis. This is a compensation for hip abductor and trunk muscle weakness. In the extension phase, the center of mass remains anterior and asymmetrical due to decreased hip extension and the retracted pelvis. This in turn affects the stabilization phase. The stabilization phase is often longer due to a decreased base of support and a continued anterior shift in the center of mass. The ankle remains in plantar flexion, making it difficult to stabilize the trunk. Quad strengthening can also be used to improve sit-to-stand by decreasing the time it takes the patient to complete the extension phase. Functional practice of a loaded sit-to-stand can greatly improve lower extremity strength and decrease the time it takes to perform the whole task by improving the efficiency of the sit-to-stand movements. The patient wears a backpack loaded with free weights for this task. The best weight to begin with is 20% of the patient's 1 rep max. From here, the weight can be gradually increased. Potential compensations include increased adduction of the lower extremity, which can be limited by placing a ball between the knees to remind the patient to use proper kinematics. The therapist also needs to monitor horizontal head movement and use of the upper extremities because these strategies are biomechanically ineffective for completing the sit-to-stand task. Wall squats with a ball placed between the knees to limit adduction can be used to improve quadriceps strength for knee extension in the sit-to-stand task. This exercise promotes full weight bearing through the entire foot, which helps limit equinus. Practicing sit-to-stand with therapeutic handling limits pelvic retraction and plantar flexion. The tactile cueing from the therapist as well as a ball placed between the knees prevents increased adduction. Upper extremity use should not be allowed during this practice because the patient has a therapist there to aid in any deviations that may occur from lower extremity weakness or spasticity.